Good morning everyone. Today I Chandra HASA is going to present you my case report, that is HIV associated non-Hodgkin's lymphoma of Gingiva. In the current scenario, HIV AIDS is a serious issue in India. HIV is a virus that attacks cells that help the body fight infection, making person more vulnerable to various infections, diseases or neoplasm. If left untreated, it leads to AIDS. Some neoplasms are associated with AIDS like Kaposi sarcoma and non-Hodgkin's lymphoma. Lymphomas affects the body's lymphatic system, and these can be divided into Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma can be identified by the presence of Reed-Steinberg cell, and non-Hodgkin's lymphoma, which are the most common type, develops from B and T lymphocytes. And oral involvement of this non-Hodgkin's lymphoma is primarily rare, but if involved, they often involves the gingiva, which shows enlargement, that is, increase in the size of the gingiva. However, due to their very clinical presentation, the diagnosis becomes challenging for the clinician. Coming to our case, a 39-year-old male patient reported to the department with a chief complaint of gingival swelling in the mandibular right posterior region. The patient is systemically healthy and is not under any medication. On intraoral examination, a soft sessile mass of 2 into 1.5 cm in size was evident on gingiva of mandibular right canine, first premolar and second premolar, on the buccal aspect. The mass was non-ulcerated, painless on palpation, and had a tendency to bleed on slight provocation. The adjacent teeth showed no caries, periodontally healthy, and radiographic evaluation revealed no bone loss. On blood investigations, the patient was found to be HIV positive by the Tridot test. So the patient was referred to the general hospital and he was found to be definitive stage 1 of HIV positive. Based on these findings, it was provisionally diagnosed as pyogenic granuloma with a differential diagnosis of peripheral giant cell granuloma, metastatic carcinoma, Burkitt's lymphoma, and a Kaposi sarcoma. How we managed our case is the lesion was excised with a light laser under LA and was sent for biopsy. The histological examination of the lesion showed parakeratinized stratified squamous epithelium and an underlying connective tissue with numerous round to oval cells with pleomorphism and hypochromatic nucleus, high mitotic figures, giving a preliminary impression of round cell tumor. For a definitive diagnosis, immunohistochemistry was performed with a panel of tumor markers, and there were cells positive for leukocyte common antigen and Ki67. And these results showed positive for high-grade lymphoproliferative disorder and non-Hodgkin's lymphoma. These are two tumor markers, and Ki67 was about 80 to 85%, and few scatter cells are also present, that is D68 and NS100. So after recall of the patient after 15 days, there was recurrence of the lesion in the same region. This recurrent overgrowth mainly involved in the interdental papilla and the marginal gingiva of the first premolar. So the patient was referred to an oncologist, and the positron emission tomography, that is PET scan, of the whole body revealed an enlarged right cervical lymph node, and so he was initiated with the heart treatment, that is a highly active antiretroviral therapy and chemotherapy for non-Hodgkin's lymphoma. So after this treatment, there is a gradual regression of the lesion and he is kept under follow-up. So non-Hodgkin's lymphoma and Kaposi sarcoma are AIDS-defining diseases and usually occurs in the advanced stage of HIV infection. But in this case, it happened as a primary manifestation which occurs rarely. So this made the initial diagnosis difficult. Various pathogenic mechanisms like genetic susceptibility of the host, prior HIV infection, antigen stimulation, modified cytokine loops with overexpression of interleukin-6 receptors and interleukin-10, tumor necrosis factor beta were involved in the lymphoma generation. HIV indirectly exerts its pathogenic activity through progressive disruption of immune surveillance against Epstein-Barr virus infected cells, which are present in the large members of the lymphoid organs, leading to neoplastic transformation. According to John Cruz, there is a spectrum of AIDS-related non-Hodgkin's lymphoma, which includes systemic AIDS non-Hodgkin's lymphoma, primary effusion lymphoma, primary central nervous system lymphoma, and plasma lymphoblastic lymphoma. Navarro et al. Reported 2 cases of oral primary extranodal non-Hodgkin's lymphoma as primary manifestation of AIDS, one on the lingual aspect of mandibular gingiva and other on the palate. These lesions exhibited an ulcerated surface with pseudomembrane pain and tooth mobility which were absent in the present case. Williams reported a case of oral non-Hodgkin's lymphoma as a prime manifestation of AIDS, which presented as a periodontal lesion and mental nerve paresthesia. A study was conducted and it evaluated 15 cases of primary oral non-Hodgkin's lymphoma, and it reported a male predilection with a mean age of 42.6 years. A presentation and of these, 2 occurred in HIV positive subjects. So the various treatment modalities include chemotherapy with the standard approach of CHOP regimen, that is cyclophosphamide, doxorubicin, vincristine and prednisone, radiotherapy and HART, that is highly active antiretroviral therapy, and combination of the above. Some proposed an alternative, that is EPOC, etoposide, prednisone, vincristine and cyclophosphamide. That is in AIDS-related lymphoma without concomitant HART. In our case, patient is under concomitant HART treatment and chemotherapy, which improve the clinical outcome by manipulating the immune system. So I conclude that the careful diagnosis and management of rapidly growing gingival enlargement is very important, as this may also reveal rare diseases like non-Hodgkin's lymphoma as well as non-diagnosed states. Thank you.